Hi, and welcome to another episode of the Pro PA podcast, where future pros in medicine are made. I'm Angie Urbina, your host for this dermatology series. Today we're tackling an important, albeit less common, dermatologic emergency: drug reaction with eosinophilia and systemic symptoms, better known as DRESS. DRESS is one of those conditions you might not see often, but when it does appear, you must recognize it quickly due to its potential severity. This reaction goes beyond the skin, affecting multiple organ systems, which makes it crucial for clinicians to understand its presentation and management. Let's get started. Let's start off with the pathophysiology. DRESS is a rare, potentially life-threatening, drug-induced hypersensitivity reaction. Unlike simpler drug eruptions, DRESS involves systemic symptoms like fever, lymphadenopathy, and internal organ involvement like hepatitis or nephritis. It is considered a T-cell mediated hypersensitivity reaction. Although the exact pathogenesis is not fully understood, two main pathogenetic mechanisms are thought to be involved: a drug-specific immune response and human herpes virus reactivation with a subsequent antiviral immune response. The majority of DRESS cases are due to anti-seizure medications, allopurinol, antibacterial sulfonamides, minocycline, and vancomycin. The dermatologic presentation of DRESS is polymorphic and evolving. It starts as a symmetric, intensely erythematous maculopapular eruption to the face, upper trunk, and upper extremities. During this time, it cannot be distinguished from an exanthematous drug eruption, but its possible progression to coalescing erythema sets it apart. Additional findings include purpura, infiltrated plaques, pustules, exfoliative dermatitis, and target-like lesions. Facial edema is also present in the majority of cases and may be a useful clue to the diagnosis. But this isn't just about the skin. Be on the lookout for systemic signs such as fever, lymphadenopathy, hematologic abnormalities like eosinophilia and leukocytosis, and organ involvement. Regarding the organ involvement, liver injury is most common, occurring in up to 90% of cases. Acute interstitial nephritis, interstitial pneumonia, and less commonly myocarditis can also occur. And let's not forget about the timing. Symptoms develop 2 to 8 weeks after starting the drug, which unfortunately can make the connection harder to spot. The diagnosis of DRESS is suspected based on a combination of clinical features, as we mentioned, the cutaneous findings and systemic symptoms, history of exposure to high-risk drugs in the previous 2 to 8 weeks, and laboratory and imaging findings. A skin biopsy should also be performed to rule out other conditions that may mimic DRESS, such as Stevens-Johnson syndrome, or cutaneous lymphomas, cutaneous lupus, or viral infections. And one last note is a scoring system called the Registry of Severe Cutaneous Adverse Reactions that helps confirm or exclude the diagnosis of DRESS. It includes the common clinical findings of DRESS like fever, lymphadenopathy, eosinophilia, atypical lymphocytes, the skin rash, a biopsy suggestive of DRESS, organ involvement, and a couple of others. Now, let's talk about the management. Management is all about three things: stop, stabilize, and support. Number 1, stop the offending drug immediately. This is a critical step. Number 2, corticosteroids. Systemic corticosteroids are the mainstay for severe cases, especially with significant organ involvement. But in milder cases, topical corticosteroids may suffice. And number 3, supportive care. This includes monitoring in a hospital setting, especially if multiple organs are affected. From a preventative standpoint, Patients who recover from DRESS should be educated about the need for strict avoidance of the offending drug as well as cross-reacting drugs. And because of pharmacogenetic susceptibility, avoidance of causative drugs should also be recommended to first and second degree relatives of these patients. Here are a few clinical pearls. Number 1. Timing is key. Remember, symptoms often start weeks after drug initiation. Number 2. Monitor closely. Organ dysfunction can worsen even after stopping the medication, so follow-up is essential. And number 3. Know the culprits. Recognizing high-risk drugs can help you make the diagnosis faster. All right, let's test our knowledge with a couple of clinical questions. Question 1. A 45-year-old man presents to your clinic with a widespread rash, fever, and malaise. He started allopurinol 3 weeks ago for gout. His vitals are a temperature of 101.5, heart rate of 98 beats per minute, a respiration rate of 16, and blood pressure of 130/85. Physical exam reveals a diffuse morbilliform rash and cervical lymphadenopathy. Labs include elevated liver enzymes, elevated creatinine, and eosinophilia. What is the best next step in management? Is it A, stop allopurinol and start systemic corticosteroids? B, discontinue allopurinol and monitor without treatment? C, start antibiotics for suspected sepsis? Or D, refer for skin biopsy? I'll give you a couple of seconds. If you chose A, stop allopurinol and start systemic corticosteroids, you are correct. This presentation is consistent with DRESS. Immediate discontinuation of the offending drug and initiation of systemic corticosteroids are critical to prevent further organ damage. Question 2. A 30-year-old woman presents with fever, malaise, and a rash. She is on day 24 of taking carbamazepine for trigeminal neuralgia. On exam, she has facial edema, a diffuse morbilliform rash, and mild scleral icterus. Labs reveal eosinophilia and elevated liver enzymes. Which of the following is the most likely diagnosis? Is it A, Stevens-Johnson syndrome? Is it B, DRESS, which stands for drug reaction with eosinophilia and systemic symptoms? C, exanthematous drug eruption? Or D, acute hepatitis? If you chose B, DRESS, you are correct. The combination of a delayed onset rash, facial edema, systemic symptoms of fever and malaise, eosinophilia, and organ involvement is characteristic of DRESS. We are not thinking Stevens-Johnson syndrome because this would present with mucosal involvement and epidermal detachment. Exanthematous drug eruption would be limited to the skin and lack systemic findings. And acute hepatitis may cause elevated liver enzymes but would not explain the rash and eosinophilia. Great job! Thank you for tuning in to this episode of the ProPA podcast. Remember, early recognition and management of DRESS can make all the difference in patient outcomes. Don't forget to hit the subscribe button and turn on notifications so you never miss an episode. And as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.